414, what's up? It's Sunday, May 2nd, and as promised, a quick review of what we did not get to. We didn't get there because I tried to get to know you guys a little bit. We didn't get there because I wanted to make sure you had this good background concept of this wellness feature in our class that was also kind of proposed throughout USC. And then lastly, I really wanted to make sure you knew diabetes, all right? Another great picture of Julia right here. That's what I call the UCLA days when we were both working at UCLA, and it was right before we got married. So it was 30 something years ago. Awesome. Okay, so there we are at Stonehenge. What are we going to do? We're going to go here. We ended up with Parkinson's disease. I'm glad we ended on this uplifting high note. The work that I did for many years with Mike and Giselle over at Keck Medical School, and we're lucky to have Ryan continue on this work. We've passed the baton to Ryan. He continues to do this excellent work in their laboratory. All right, now we're going to look at the polar opposite. Now in Parkinson's disease, remember there is too much freezing up of the thalamus. The output of the basal ganglia is too strong, and you do not get purposeful movements coming out. All right. In what we see right here in Huntington's disease, this is a normal brain, and then they put right next to it the brain of somebody with HD, and you can see this massive degeneration of the entire striatum, which is the caudate epithelium and basal ganglia right here. You see right here, this would be the output that would normally be inhibiting the thalamus. You can see how diminished it is right here. So how does this happen? Remember, Parkinson's was 95% environmental and maybe 5% genetic, autosomal dominant cases. Genetic cases that had to do with protein handling. Okay, the autophagy process was messed up, and then also mitochondria. So same drill here, except for it's one single protein. All right, it's a protein called huntingtin. It's a synaptic protein, was discovered by looking at people that had Huntington's disease and then backtracking into animal models and figuring out what the protein did. So it is an essential part of our brain's function, nerve cell plasticity. But when it gets these triplet repeats slapped on, CAG, on and on and on and on again, there's a number of genetic triplet repeat disorders that happen in humans. But when that happens, then it changes the function of the protein. The protein gets very sticky, okay, becomes toxic to the mitochondria, and it becomes resistant to degradation by proteasomes. And so we know the drill. It begins to accumulate, and it starts in the caudate epithelium, okay, but it will then progress to the cortex and other regions. The earlier onset disease reflects the greater number of triplet repeats. All right, so it is a natural part of genetic shifting and spread, so it can emerge spontaneously as well. Alrighty, cool. So we remember Parkinson's disease, okay? We had the issue of not enough output by the thalamus, okay? And so we can emulate bursts of dopamine that would normally go after the D1 dopamine receptors that free up certain movements, free up those applications that we talked about, okay? Here in Parkinson's disease, the dopamine that we needed in those bursts that would free the system up is gone. So we supplement it with Cinemet that gives you extra dopamine, or we can use dopamine receptor agonists, okay? But it is kind of a situation where you're frozen. The thalamus is not having enough output to the cerebral cortex. I'm going to emulate this now for Huntington's disease, okay? Here, it's not the dopamine that's dying off, it's the striatum of the basal ganglia that's dying off. In the end, the thalamus no longer inhibits any of, in the end, the basal ganglia no longer inhibits any of the thalamic circuits. And so you have all these movements that would normally be inhibited would have the brakes on, the brakes are released, okay, and you have the choreiform movements. All right, this is a great 60 minutes documentary about it. Check it out. We're not going to have a chance to do it. You remember the choreiform movements, what they look like. If we look, In terms of treatment, it's going to be the opposite we see in PD, right? We're trying to free up movements by emulating the bursts of dopamine that happen when you have an intentional release of movement application. Here we have basically movement applications just free running all over the place. So you're just going like this and you're moving all over the place and you're writhing. And so we need to tone that down. So what you do is you give drugs that will block the action of dopamine. So we have the antipsychotics, okay? These are the dopamine receptor antagonists, okay? So it tones down the action of dopamine, and so for what's remaining in the striatum, it'll tone down the freeing of those apps, okay? Another fairly recent drug is called tetrabenazine. It depletes the amount of dopamine that synapses will normally release, okay? Alrighty. And then just kind of a moral and ethical thing. When the gene was discovered, many patients decided they still wanted to have children because what happens, it starts creeping in your late 40s, early 40s. You're going to have it because you did the genetic testing. You can do in vitro fertilization. You can then pull out cells from the embryos and test whether they have the gene or not, and then select which ones don't have the gene and implant it. So that's all. Okay, so that's Huntington's disease. We're going to now get our way into, and I was kind of reviewing here, dementia. We should have an entire course on dementia, obviously. There are many different pathologies. The most common is Alzheimer's, although there is some controversy about the crossover between Alzheimer's disease, sorry, that's me being a dopey dope, okay, between Alzheimer's disease, okay, and vascular dementia. All right, so yes, there are many different forms of dementia. So this kind of goes through all of them. It doesn't even, it's not even listing Alzheimer's, okay, but you can get dementia from Huntington's. You can get frontotemporal. You can have hydrocephalus, okay. You can have Parkinsonian, mixed dementias, everything under the sun. All right, so. When you're looking at dementia, remember we don't have a blood test. Using scans like an MRI or a CT perfusion or anything like that we've seen that was very useful in stroke is not useful because by the time you detect up that kind of pathology, the ship has sailed. There's so much pathology, they would be in late stage dementia. Not that we have anything right now to slow it down. All right, but it's, you want to categorize it, all right? Plus, and you would do this post-mortem by looking at the brain. It's important, though, to know whether or not you have some reversible forms of dementia. I mentioned it last class, delirium, which is kind of almost like a toxic shock type of thing, where you can have a really toxic psychological episode. You can have a really toxic physiological episode. You can have an adverse reaction to drugs. All these things can put you into a really high level of adrenaline rush. Cortisol gets released, and it can cause this reversible dementia. All right, and we call this delirium. All right, we can also do blood tests, kidney function tests, liver function tests, and try and figure out if there's something that is treatable and reversible. And then you find out if your patient's had a recent brain injury. All right, again, with time, that can be reversible. It just depends. All right. All right, so this is, again, the pamphlet that I sent out about differentiating between delirium and dementia. Delirium being very acute, so it comes out of nowhere, okay? The dementia is a slow, progressive disease, and that'll be a key to your diagnostic feature, okay? The delirium will then disappear, okay, get better, whereas dementia does not, all right? Another cool website right here that you can check out, just looking for sociological trends and really about the numbers and what we need to kind of do in this future in terms of society. All right. Now, I did bring up the concept of traumatic brain injury, TBI, and how if you have a number of TBIs, it can have what's called chronic traumatic encephalopathy. Okay. And the connection between this and between strokes and between Alzheimer's is the blood vessels. The blood vessels become leaky, they become inflammatory, the immune system goes in there, and it wreaks havoc just like everything that we've seen, okay? This is kind of a nice overview of the brain losses that you might see, the degree of brain losses, and what you might see in terms of the behavioral pathology. When we look at dementia, then this is the traditional pie chart, okay? Again, Alzheimer's being the biggie, all right? But that being said, right behind it is cerebral vascular disease, and this would be identifiable, small transient ischemic attacks that then later on become full-blown ischemic attacks to the brain, okay? There is a lot of crossover here, okay? A lot of controversy out there is that whether or not this is just one big continuum, okay? Do we see the plaques and tangles that we're going to talk about later on, the activation of abnormal activation of some enzymes consequent to blood vessels now, the blood-brain barrier not working right, okay? Nobody knows, okay? I think it's still wide open, all right? Lewy body disease, again, this could be from environmental insults, much like Parkinson's disease. And then frontotemporal dementia is a really unique one, and we're going to see it's unique in its primarily tau pathology versus the plaques that are present in Alzheimer's. Okay, tau makes up the tangles. All righty. AD accounts for at least half, if not more, of the cognitive impairments, and it impacts the greatest risk factor is age. All right, and like I said, some form of cerebral vascular pathology is pretty much universal in people when we get up into this age range, and so they're likely to have multiple pathologies when you're looking at it. Again, looking at the impact of age, you can see as you march forward that you start getting up in here in terms of the percentage of the population, and in some accounts, really, this is just one individual study, but about a third of people over age of 85 have some form of dementia. Okay, which is really scary. Okay, and we look at again, the numbers, okay, projected, and you see by age group, the over the 85 age group is the biggest collection of people. They're the most vulnerable, the most feeble, the most dependent, most likely to get this disease. We can see over here the cost is enormous, okay? And this is in 2021, and we see the projections out there by 2050 because we know that people live longer, and as a consequence, age being the biggest risk factor. Again, this is just another one looking at, again, 1 in 3 seniors dies with some form of dementia, which is tragic. 1/3 of people over the age of 85 are affected in some way by this illness, and we can see the proportionality as a function of years right here, okay? So if you see that 38%, okay, in this particular flyer put out by the Alzheimer's Association, have over the age of 5 have dementia. All right, cool. All right, so symptoms, you're going to look at psychological change, the patient self-reporting, not always totally reliable. That's where you're going to have to look for a caregiver to get some insight. You're going to perform a mini mental status exam, okay? We'll talk about that. You can look for changes, mood disorder changes, psychiatric changes. We'll see whether or not the descending cortical influences on reflexes are being impacted. And then what the last thing to do is imaging. And again, the problem with imaging is the disease has progressed pretty far before you're able to detect it with any type of MRI or CT. This is a great website to look up, and we just kind of look at these changes, okay? And again, it's you have to become a cognitive expert and also a psychiatric expert, and looking for changes across the spectrum of behavior. This is an example of a really great example of a mini mental status exam that is being done on this woman, and I think I've already loaded it. Let me take a look right here. And so we'll look at this screen for dementia and this woman.
About your memory, and we'll be about 20 minutes to a half hour, okay? So I can get some idea about how you're thinking. Have you had any trouble with your memory?
No.
No, it's been pretty good, huh? Yeah. Do you know what day it is today? Monday, Tuesday, Wednesday, Thursday?
Look at her eyes. She has no idea.
I told you I was going to be annoying. Can you give me your best guess what day it is?
I'd say Thursday.
What typically I think you would do is do a short battery, and off that battery where you see deficits is to push it. You'd not go beyond 2 hours, maybe 2.5 hours. What do you notice that's a problem for you? So you'd want to get a read of their cognitive domains, and largely they involve attention and language, visual, spatial, memory, and executive functioning. And you'd want to get a sense of their baseline, where they were in their life, what their premorbid personality and intelligence is. And based on that information, along with their affective status, whether they're depressed, anxious, somaticized, and having difficulty with agitation and suspiciousness, they tend to be the 98% of the problems that you get with people. And you've not really noticed anything that's terribly different for you over the last 2 or 3 years, huh?
No.
Okay, okay.
So
Things are pretty good at home?
Mm-hmm.
Your mood is pretty good? You eat okay?
You can see the problem with self-reporting there, all right? And this is why you need to go beyond that, just to self-reporting.
Hey, you're feeling okay?
Yeah.
That's good. That's good. And everything is pretty cool with you and your husband, huh?
Mm-hmm.
Great. How many children do you have?
2. None now.
None now. But you had how many?
Just the 2.
2. What were their names?
Beverly and Billy. They both were married.
They both were married? Where are they living now?
We don't have any children right now. We did.
Once you get an understanding of those components, you then can pretty much help the person where they're at and make a reasonable projection of what needs to be done in the next 6 months to a year with where the person is going to be. Do you get feelings about that when you do talk about them? Mm-hmm. You do. So right now, are you feeling a little sad? Mm-hmm. Okay. Thank you for telling me. Now she is down in attention, she's down in language, she's down in visual, spatial, she's down in executive functioning, and her memory is atrocious. Not only her short-term memory, but she can't remember when she was married, where she grew up. She gets her kids confused, so she's impaired. So we saw that in the assessment that was given to her, and we did a light battery in the sense I wanted to get a sense about each of the domains without getting absolute numbers in all of them, because that wouldn't serve us very well. This woman is so impaired. Do you find yourself sleeping a good deal during the day?
No.
No. Do you sleep okay at night?
Mm-hmm.
You do? Okay. Are you tired during the day?
Sometimes.
Sometimes. I noticed you were kind of nodding off when we talked a few minutes ago. Did you notice that?
Yeah.
You did, huh? So you'll do that on occasion, huh? Okay. Do you do much reading or do you watch TV?
Both of those things, yes.
You do. What's your favorite television show?
I can't think of them.
Okay.
Just turn them on and watch them.
You just turn them on and watch them. What's your address? Do you know your address at home? What is it?
It's 78
78
Curtis Street.
Curtis Street. And what town?
You see her affect as well, her facial affect, her expression.
When I'm done, okay?
Mm-hmm.
Apple, penny, table.
Apple, penny, table.
Super, super, super. Can you do me a favor? Can you pull out your mathematics hat and subtract 7 from 100? It was clear that she did not need a lengthy battery, that what we were into was someone in the moderate stages of dementia.
93.
Good. Her memory is not going to be her friend. Do you remember those 3 words I just asked you to remember?
No.
You remember any of them?
No.
No? For example, she could not remember 3 items within 1 minute's time and could not do that over a period of time. She also had poor visual spatial skills to such an extent that she didn't quite realize that the 2.
So you can see how this test is run, and that's something that you would be doing then in your practice. Okay, cool. What I also, recommend you take a look right here. This is a pretty compelling video. And we're not going to watch the whole thing about what it's like to do caregiving for somebody that is like the patient we just saw.
See, very good. Yeah, to the kitchen table. I'm going to give you your guava pie.
Maite Garcia takes care of her mom
Nice
who has
job.
Alzheimer's,
Okay.
87-year-old Maria Garcia. Each morning, Maite bathes
Nice
her,
job.
dresses
Mama.
her,
Oh, Mama,
cooks
te
for
toca la
her,
pastilla.
spoon feeds her, gives her all her
Ahí está.
medications,
Did you wanna
sits
watch
with
some
her,
TV?
and then
What
it's
do you
off
wanna
to
do?
work. After a grueling day at the office, Maite returns home to start the routine with Maria all over again in the evening.
It's very difficult. It's very difficult when you are looking at someone and they're different now. You know, they're not the same person. And part of me is caring for her because I'm honoring who she was before.
You want your water?
And part of me is trying to honor and deal with the person she is now. My old mother was a dynamo.
How is Mom now?
She just really doesn't want to do anything. People see her like this, and that to them is
Again, you can see the lack of affect on her face. So it's really, really difficult, and this is why we need to do better in terms of, how we're going to be caring for older Americans, because like I mentioned, these numbers are only increasing. The sociological demand is only increasing, okay? Alrighty, when we look back at the patient that was having the mini mental status exams, we see that the maximum score is 30 points. A score of 20 to 24 suggests mild, 13 to 20 suggests moderate. In this particular case, she had a score of somewhere between 12 and 13, so she was pretty severely impacted. Okay, all right. Like I said, there are many, many different forms of dementia. Okay, we see it. I listed them down here. We have Alzheimer's disease, frontotemporal dementia, diffuse Lewy body dementia, Creutzfeldt-Jakob, which is a prion disease, and then vascular dementia. These are every table is, it depends on the study it's done, but there are a wide variety of reasons as to why somebody might be demented. You're going to combine your psychological presentation, okay, some of the first symptoms, with the mini mental status exam, neuropsychiatric, how the person reaction time, the person's reflexes, things like that. I'll look at muscle tone, like I said down here, and then imaging. Alrighty, cool. This is the future, okay, that hopefully we will be able to have biomarkers as indicated down here, and watch their progression over time. That's the goal. There's a lot of, so sorry about that. I'm always trying to grab my arrow. Here we go. A lot of research looking at things like cerebral spinal fluid A beta 42. We'll see this is the toxic protein segment that is characteristic of Alzheimer's disease. The small bits and pieces of amyloid beta, okay, that comes from amyloid precursor protein, aggregates to form the plaques. Before they form plaques, they're all throughout the brain, and they're toxic, and you can just pick them up sometimes in the cerebral spinal fluid. And so the goal then would be to monitor. We see right here that the purple dot, the progression of this biomarker over time. Okay, this one is expensive. It is being done, okay, and this is, you see it tracks the cerebral spinal fluid. This is looking for positron emission tomography, where we actually have a radioactive label that would bind to the amyloid plaques, okay. We can look at another protein, tau, in the cerebral spinal fluid right here, okay. This is magnetic resonance imaging along with how well the brain uses glucose. This is fluor deoxyglucose PET. Again, these are all different types of tests. And you see that cognitive impairment is a psychological test, and this is fairly late in the game. Fairly late in the game. All right. Again, something that's in the future is to correlate inflammation. All right. We see that when we look at cognitive impairment, okay, we see we have the glial cells and how they function. We look at inflammation coming from not only bad glia, as shown right here, but it also can come from peripheral invasion of the brain. Okay, this is a really cool article by Harvard Magazine that looks at inflammation being causative in a myriad of diseases. Okay, myriad of diseases, including Alzheimer's disease. All righty, cool. Something else to consider. Okay, 80% of people with Alzheimer's disease have insulin resistance or type 2 diabetes. Okay, so we've learned all about the impairment of endothelial function, the breakdown of the blood-brain barrier. We've learned about atherosclerosis, okay, and having mini strokes, but separate from that, it's just an ongoing inflammatory vascular disease, but it's happening in the brain, okay? And there's significant leaks, and we kind of studied this whole concept, remember, with high levels of blood glucose, triggering rage, that put you at risk for throwing clots, as we sound here, okay, and you guys remember tissue factor, okay, so that's what's being thrown out here. But we also see the many inflammatory proteins over here, and then we have over here the pathogenesis that happens in their vasculature that leads to atherosclerosis, cell adhesion molecules, and all the fun and games we've learned about, okay? All right, diabetes, vascular disease, inflammation, okay? So this is another great story about leaky blood vessels, which is connected to Alzheimer's disease. This is a wonderful, long, okay, about 25-minute long documentary. It's not really a documentary, it's a 60-minute show. Looking at people that live in their 90s. It comes out of UC Irvine. Watch it. And what they found, as I kind of put down here, they started doing PET scans for plaques, okay, which again is like the official readout of Alzheimer's. We'll see that later on. And we see at the very top here that this particular patient had a minimal PET scan marking of plaques. Again, this is just a radioactive label that will bind to the plaques. And then we see somebody at the bottom that had just massive amount of plaques. They were both sharp as a tack in their 90s, showed no sign of cognitive impairment. So it shows you this kind of disconnect that can happen. They also talk in this video, this documentary from 60 Minutes, about that when they go in and they look at patients that did have dementia, that a lot of them it was vascular, right? No evidence of plaques and tangles, but little tiny strokes everywhere, okay? All right, this is, like I said, it's a UCI study. Check it out. This video right here shows you kind of a brain dissection you'll be doing as a pathologist to quantify the loss of volume of brain and how it's progressed from cortex to other parts of the brain. We'll look at the underlying causes, the etiology. We're going to hone in on genetics, okay? Both autosomal dominant and autosomal recessive. Just a couple, but there's the field of genetics is exploding in Alzheimer's, so I can't cover everything. And but a big thing that I want to remember is the outside influences: heart disease, diabetes, head injury, level of education. These are environmental factors. And then things like diet, exercise, sociality, and your body weight. Later on in life, it's actually good to be a little bit heavier, okay? So this gets into this vascular concept. I just did a search right here. This is my Google search. I just said capillary inflammation causes dementia. When you look at this, thousands of articles come up, okay? And again, this shows you right here, the title of this article, and I put the link up here. It's just the impairment in capillary function that is in early Alzheimer's disease. When we go down here and start looking at the genetics now, so we're going to go back here, all right? So I'm going to jump into genetics of Alzheimer's disease. We see that much like Parkinson's, okay, there is this autosomal dominant. We see that categorically it can be early onset dementia or later onset dementia. So this would be late 40s, early 50s, and this would be more you'd be seeing in 70s, 80s, and 90s. Okay. If we then do a deep dive into the categorized early onset. We see roughly 6% are this autosomal dominant. Okay, you inherit this gene from your parents, you're going to get it. We see sporadic, meaning we don't really know, and then we see familial, which is somebody in your family had it. You don't have the autosomal dominant variant, but you have other genetic risks. Okay, and we're gonna the one that is by far the most studied is the one that is remember the apolipoproteins we talked about in terms of carrying triglycerides and cholesterol, but this one is the exchange protein called ApoE, and we'll look at the variants on that. It's the one that's again is probably the one that is best determining risk. Okay, late onset, this would be 70s, 80s, 90s. There's a lot more just kind of unknown. Okay, in terms of, and it's just an accumulation of environmental damage. This is a little bit of reading that you can do associated with that. Okay, all right. In terms of environment, okay, right here, you know, like I said, this is such a really neat aspect to study because sometimes it's a matter of choice, diet, exercise, stuff like that. Okay, and so if we come back over here, you know, I'm looking at these, you know, environmental things that can be modulated, right? And then this was a great article right here where it's looking at being a sleuth, a detective, where you're looking at the kind of, you know, geography, demography, where in our country are there some hotspots, you know, and if there are, that, you know, sure, that could be genetic, but it could also be a large part environment. And this is, you know, right here, this is this is a really cool article in the Wall Street Journal. And you can see this aggregation of hotspots down here in the South. Okay, not as so bad out here. Again, these are, you know, certainly there are going to be more popular, less populated areas, but you can see that there's this large aggregation down here that we're not seeing all through the West Coast and Pacific Northwest. So something's going on here in terms of the prevalence by county for these diseases. All right. And in this particular study, then they actually looked in, you know, in county by county basis, and they, you know, looked at Black, Latino, White, Black, Latino, White. The darker has the highest prevalence. Okay, the lighter has the lowest prevalence. Okay, and when we use these ethnic categories, so you see that if you have a bachelor's degree, okay, then it's going to, in that county, result in a little bit more protection, and that's all that's showing right here. Okay, alrighty. Being in poverty, all right, puts you at risk. Okay, exercise opportunity protects you. Okay, again, that's what this shows you right here. Okay, awesome. All right. These are cool videos for you to watch if you want to look at the progression, a nice overview. Okay, I'm going to get into the nuts and bolts right here. So when we're looking at the genetics, again, I jump back to environment. So now what I want to do is I want to jump back into genetics and what's going on in terms of Alzheimer's disease. But look at genetics. We come down here, we see that we had the key player, and this is this amyloid precursor protein. So it says beta amyloid PP. All right, it's beta amyloid precursor protein. All right, and it is ultimately the source of amyloid beta peptide. Amyloid beta peptide is not put out there to be giving you Alzheimer's. It's a variant of the amyloid beta peptide. Okay, the 40 amino acid length is actually stimulates plasticity. It's kind of acts like nerve growth factor, gives elongation of dendrites. But if it's not processed or clipped correctly, then you get the 42 amino acid length version, and this one is toxic. Okay, alrighty. And there are lots of influences. This article is kind of honing in on the many different types of influences. All right, so pathogenic mutations. Okay, like I said, you know, 5% of these, less than 5% of these, are accounted for. This would be the autosomal dominant variations that we're going to talk about. Okay. Less than 5% of all people with Alzheimer's, okay, have these mutations, and this is the different types, okay. So there's a little gray area in terms of what's called familial, okay. But if we look at these, these are the ones that are highlighted. Chromosome 21. This is where the actual amyloid precursor protein is mutated, okay. So it doesn't cut correctly, and it makes these 42 amino acid lengths, or the clipper, okay. This gamma secretase. So we have a beta and gamma secretase. And we look at this presenilin 1 mutation, presenilin 2 mutation. They both are subunits that make up this gamma secretase that clips the A beta. You clip it wrong, you get the 42 amino acid length segment, and it then, as shown down here in the bottom, begins to form these oligomers that are toxic that can relate to the end point, the plaques. It's not clear if the plaques are actually toxic. Some people believe that the oligomer, the pre to forming the plaques, is toxic. There's evidence that the oligomers also will cause a second type of pathology, and these are the tangles that are from hyperphosphorylated tau, a protein that's key in terms of the cytoskeleton, okay? All right, so we look at chromosome 21, okay? So this is my amyloid precursor protein, okay? And when it's the amyloid precursor protein is clipped, you make an abnormal length segment, okay? So that would be one type, all right? Alrighty, we look down here, okay, so these are the 14, you don't need to know the chromosome numbers, but there's presenilin 1 and 2, okay, so that's 14 and 1, okay, and they make up the gamma secretase that we show right here. See the scissors, and so it does the final processing, okay, so instead of going this route right here, which is the altered APP, the APP is fine, but then the gamma secretase cuts it incorrectly up here, okay? In the end, it forms the 42 amino acid oligomers, and they're toxic, okay? And you end up forming the plaques that we see right here, all right? So the key is increasing the ratio of A beta 42 to 40, 40 being normal, 42 being abnormal. All right, this right here is a great video that shows you the animation of what's going on. This is just two different clips of the animation. The one is when the beta and gamma secretase. So this is showing the beta secretase, but there are two scissors. One's on the bottom, one's on the top. One's beta, one's gamma. And the autosomal dominant versions are both problems in terms of gamma secretase. The other thing, this is another key element here, is the hyperphosphorylated tau, and again, these are cytoskeletal proteins. This has been shown to be influenced by, in terms of the activities of these secretases and the likelihood of producing abnormal A beta 42 is modulated by diet metabolism. So we see it more frequently, the 42 with people with diabetes and atherosclerosis. There's a genetic risk modifier. So like I said, this ApoE that is part of our cholesterol carrying protein package. There is a variant that puts you at risk. So we're going to learn all about ApoE2, ApoE3, and ApoE4. You're more likely to have ApoE3, but some of us have the E4. If you're heterozygous for E4, it's not as bad. If you're homozygous E4, it's super bad. And what it does is it puts you at risk for diabetes, vascular disease, and Alzheimer's. Okay. All right, when we're looking at these guys, okay, we see that again, high levels of A beta 42. That's the risk factor right here. Okay. I put down here the more soluble forms are directly toxic. Okay, that's the oligomer before you form the big plaques. Okay, and these really start the ongoing deleterious consequences, and that would be the oligomer. All right, what do you see? You see atrophy of the brain. So you're seeing just a pathological study up across the top. You see the giant spaces happen in the brain. We see on the left-hand side, we're looking at the plaques and the tangles, and then on the body, we can do immunocytochemistry for these the elements that make up the plaques and tangles. So on the left, it would be immunocytochemistry or immunohistochemistry for the amyloid beta protein. On the right, it's for the for hyperphosphorylated tau. All right. Cool. All right. So when we look at frontotemporal dementia, okay, we see that there is, again, a unique genetic variant for this, okay, very rare, okay, would be very early onset frontotemporal dementia, and the A beta deposits are not a characteristic feature of this disease, but huge development of tangles from the hyperphosphorylated tau are part of this disease. So we can contrast, Alzheimer's disease, okay, from what are called tau pathologies, and this would be frontotemporal dementia. They have a different course of the disease. You see that there's no plaques, but there's tons of tangles. Here we see there's big plaques and tangles. So Alzheimer's has both plaques and tangles, whereas the tau pathology is a feature of frontotemporal. Okay. Alrighty. So what happens in this hyperphosphorylated tau state? We see it right here in this figure right here. That early in Alzheimer's, it's mostly A beta, but that the tau comes later. Okay, that would be in contrast to frontotemporal. Okay, where tau comes immediately. All right. We have genetic modifiers, like I said, ApoE. We can look at this right here, that these genetic modifiers. We're looking at early onset versus late onset. Like I said, I've gone over this figure before, and so what we want to do is we kind of want to hone in on these different familial Alzheimer's disease risks, okay, separate from the autosomal dominant, okay. What are they? What's going on here, okay? And we see that there are so many different variables that are coming in now. So this one right here, okay, is such a small percentage of the total genetic cases. Okay, so this is a true FAD that is autosomal dominant. Then we have all these other different risk genes. Okay, ApoE4 is the one that is most highly studied, but there's been GWAS studies looking at gene variability, looking at single nucleotide polymorphisms, and we're seeing more and more unique genetic contributors. Okay, so we look at 60 to 80% of risk. Doesn't mean you're going to get it though. And then we have over here environmental risk, components. Okay, this is modifiable, education, diet, all that stuff. So we see yellow here to yellow here. Like I said, this is the autosomal dominant. All these other ones are really genetic risks so far. That's what we looked at. If we hone in on the ApoE4, this is what the population looks like. And so we see, again, this is, you look at mom and dad. Are you E3, That is most likely, okay? Are you ApoE4, E2? That many cases, E4, E3, E2. This is the most protective. These people don't get Alzheimer's. This is the E2. Okay, so in ApoE4, E4 is the highest risk group. When we look at what's happening, okay, so this would be my cholesterol carrying protein, my apolipoprotein. It's got triglycerides, it's got cholesterol, and we've got ApoEs, okay, ApoEs, whatever it is, 2, 3, or 4, okay. It's a major cholesterol carrier. Our brains are all lipids and cholesterol, so you need it for lipid transport, injury, repair in the brain, okay. These proteins bind to cell surface receptors, okay, but they also bind to hydrophobic amyloid beta, okay, and it's thought to initiate, if you have E4, initiate some of the toxic events that are generated by the oligomers. And this is kind of a model that just kind of shows this happening, where these guys, the A beta binds to E4, and then you trigger the beta oligomers and in the plaques that can be very, very toxic. Awesome. Okay, cool. Again, another great video that kind of illustrates what's going on here there. All right, check these out. I'm just going to blow right by these, okay? And we're going to go into drug treatments now. Okay, what do we use? Okay, medications for memory loss. We have a limited spectrum. Okay, the first ones are the drugs that modify the action of acetylcholinesterase. So just like we have dopamine going throughout the brain, we have acetylcholine that goes throughout the brain. Small nucleus sends its axons throughout, and it's kind of like the volume control. So when you're thinking about something, you're trying to retrieve a memory, then we kind of crank the acetylcholine, and it facilitates the activity of the synapses underlying that memory. So when you're having trouble getting those circuits to fire, why not give it a little volume? And that's the concept here, all right? So we see down here, concept of a cholinergic synapse right here. And when we're looking at our cholinergic synapse, we can see that what happens is we release acetylcholine, and then there's an enzyme called acetylcholinesterase that will turn it back into the building blocks, choline and acetate, gets resorbed, and you make it all over again. So the idea is we have drugs, Aricept, Cognex, Exelon, Remenil. These are all acetylcholinesterase inhibitors. So that means when you release the acetylcholine, it stays out there longer. Okay, it's just a finger in the dike. It doesn't stop the progression, and it barely works. Second type of drug that was the newest kid on the block. This is called memantine, also known by the drug name Namenda. And was with great hope that this one would slow the progression because of maybe Alzheimer's is like cytotoxicity, okay? And also increase our ability to pick out information from that really abnormal cytotoxic noisy background. So this is synapses firing irregularly all over the place because of this abnormal release of glutamate. So you can't pick up a signal from the noise. So the idea is you put in memantine that is a low affinity antagonist of the NMDA receptor. So then the level of activity is markedly reduced, okay? Because the low amounts of glutamate are not able to displace the memantine, so the cell doesn't pick up on that, okay? However, when something is important to happen, you got to remember it, you got to act, you get a lot of glutamate released, and because it's low affinity, it kicks it off, and it activates the receptor, and you get, boom, this signal right here. So you're able to get signal above the noise, and it helps you in terms of your cognition and perception. Should help in terms of progressive disease. Another kind of crappy drug that doesn't work that great. This right here is trials, all right, that's ongoing. And I think I have that right here. So this is the website that shows you a number of the trials. It's a really great NPR website. Kind of goes through what's going on. So we have right here, this is an antibody, okay? So again, you would infuse this antibody, and it's antibody raised against amyloid beta. So hopefully it would reduce the plaque load, okay? And also the load for the oligomers. So these types of studies have been gone and on and on and on. The initial antibody studies didn't work out. This is a new type of antibody, and it shows promise, okay? Ongoing problems, this will be a new drug that's dealing with some of the, not the cognitive, but the psychological problems. And there are hallucinations, delusions, so that's being used for that. This is a drug that increases growth factor release. That would hopefully cause growth of nerve cells. This one right here is being used for people that are homozygous E4, okay? And what it does is it alters the processing of the amyloid beta, okay? Yeah, so it's some interesting new directions, okay? But we have an issue, you know, we have an issue. I talked about this in the very beginning of class. Not enough money is being thrown at Alzheimer's, and drug companies do not find it profitable. So we see here Pfizer halted their research into Alzheimer's and Parkinson's because they just weren't really able to make enough money off it. And that a lot of other drug companies followed suit. So what can we do to improve things? Physical exercise, cognitive engagement, okay? So a lot of you guys were doing this in your clubs over the pandemic, which was awesome. Music therapy. We also heard about diet being important. This is the very first thing we watched in class in terms of music therapy. Pet therapy is good, okay? All these things are wonderful. Let's get back to some other causes of dementia, okay, that are reversible, all right? So you can have vitamin B deficiency, endocrine disorders. These are all things you'll be able to pick up with blood tests. Do you have vascular disorders that are as a consequence to something like an autoimmune disorder, like lupus, okay? Do you have infectious diseases? As we see here, meningitis, or we have encephalopathy from AIDS. On and on and on. You need to rule out all these reversible forms. Okay. Do you have a UTI? It can cause these problems. Okay. These are the other causes of dementia that I talked about at the beginning. So there's so many. Like I said, we could have a whole class devoted just to dementia. We see chronic traumatic encephalopathy or traumatic brain injury. Okay, both of these can cause dementia. Okay, it all has to do with brain damage. Sadly, it's a breakdown in the blood-brain barrier, and you have cerebral inflammation. This is a prion disease. We all carry prions, and for reasons that are not fully understood, these prions can suddenly explode. There are also exogenous prions that we've heard of. We've heard of mad cow disease. Okay, there's one that comes from mink. If you eat your ancestors' brains, kuru. Okay, alrighty. This is related to alpha-synuclein. So people with Parkinson's disease do get dementia as the disease progresses. There is a non-Parkinsonian dementia with Lewy bodies, and there's a lot of research trying to figure out if this is related to the gut microbiome and the transmission of the alpha-synuclein that forms in the enteric nervous system down in your gut up into the brain from the vagus nerve. Okay. Trisomy 21, all right, so chromosome 21 is where the gene for amyloid precursor protein resides. So just by pure load, having 3 copies of trisomy 21, everybody that has Down syndrome also gets dementia, all of the Alzheimer's variation later on in life. It just overwhelms the system. This is from alcoholism. So an alcoholic has really, really poor absorption of thiamine or vitamin B1. And so it's reversible if caught early. And so this is why it's really important sociologically, if we look at places like Skid Row, that we make sure we get vitamins to support these people. All right, what else do we have? Frontotemporal dementia, I talked about that. There are genetic variants, okay? There's an amyotrophic lateral sclerosis that is associated with frontotemporal dementia from this gene right here. It has completely different behavioral symptomology. Okay, this is a video that kind of will show you the uniqueness of frontotemporal dementia. This guy has autosomal dominant version, very early onset. And let's take a look at this guy real quickly. We don't have to watch the whole thing, but
Dementia is a problem of the elderly, right? Generally, that's true, but there is one form of the disease that can strike people when they are very young, in their 20s or even their teens. It's called frontotemporal dementia, or FTD, and while rare, it devastates lives by rapidly turning young, vital people into those who need constant care. More from Mayo Clinic.
And we were seeing our son disappear before our eyes, little bit by little bit.
Sue and Bill Bishop are watching a disease called frontotemporal dementia, or FTD, consume their son Brad. The brain disorder with no cure is changing him from a caring young man with a bright future into a person whose behavior is erratic, childlike, and at times inappropriate.
Who is it?
I don't know, let's check.
Who is it?
I'll have to see who's calling.
Who is it?
It's not Brad. It's Brad's body. Of course, even that's different. Brad's first symptoms were subtle personality changes. He'd forget to return phone calls and emails. He'd act childlike in public, and he grew self-centered, a trait his parents say was completely out of character. And as the disease progressed, symptoms got much worse. Brad became agitated around people, and he couldn't control the urge to eat. So we literally had to put locks around the fridge and freezer. For more than a year, doctors did not know why this was happening. When we were told that there was something rapidly, progressively attacking your son's brain, and we don't know what it is, I lost it.
Just going to check your reflexes here.
Then the bishops met Mayo Clinic Dr. Brad Beauvais, an FTD specialist.
That's when we started on our journey. It was a long, painful journey, but at least now we know what.
And that's all you get. You know, there's no treatment for this. So, yeah, it's pretty tragic. And they showed this unique genetic variant here early onset. I had a buddy who was a great artist. Let's see here. I'm going to go back to the PowerPoint slide. Let's see if we can. Yes, there is a. Well, sorry, I'm really bad with my 3 dimensions, but there's a painting over there of the ocean. Okay, my buddy painted it. And yeah, he was a very successful artist, and we used to surf. He was a great surfer. And then to see him. We hung out for a good 15 years surfing, and he was about 50. And then all of a sudden, I stopped seeing it, and then lo and behold, he died of frontotemporal dementia. So tragic. All right. Again, other non-Alzheimer's forms, Creutzfeldt-Jakob. This is a prion disease. Prions are weird. They're not proteins. They're not a virus. They're proteins, little strange proteinaceous globs that come together. We've heard of them before. Creutzfeldt-Jakob disease is the one that is sporadic and happens. Is the most common form of prion disease. There's inherited. There's acquired. I remember Kuru. We also had mad cow disease, and scrapie right here. All right. Just more information on Creutzfeldt-Jakob. Don't forget about alcoholism right here, and B1, and that is Wernicke-Korsakoff's. Lewy bodies, already talked about that, and that has to do with alpha-synuclein seen in Parkinson's and seen in Lewy body dementia. I'm getting through this fast. Okay, cool. Good question. Is chronic stress a part of that? And I take you back to this. This is this great 60 Minutes episode about brain aging, but it also talks about the older people in their study that did show Alzheimer's disease, dementia. They weren't sure if it was Alzheimer's, and then it kind of played out in terms of whether it was vascular, whether it was plaques and tangles, and it really is kind of it's not completely solved. And I kind of want to leave with this guy right here. This is done at UCI, the Mind Institute, that this particular 60 Minutes episode is all about. Some of the people that work in it. It's really cool place to go check it out. So check this link out. Check out the Mind Institute down at UCI. All right, so what I'm going to be doing is, that's just my not so quick overview, but I'll be sending out as well the study guide, and we'll see you come finals day. Do get in there and finish up all the discussions, okay, guys? And I'm looking forward to looking at your pamphlets, all right? So with that, what I'm going to do is I'm going to end my session right here, and we'll see you next time.